Management of Breech Presentation. Green Tab Guideline Number 20B, March 2017. Introduction and Background Epidemiology. Breech presentation occurs in 3 to 4% of term deliveries and is more common preterm. It is associated with uterine and congenital abnormalities, has a significant recurrence risk, and is more common in nulliparous women. Term babies presenting by the breech have worse outcomes than cephalic ones, irrespective of the mode of delivery. Publication of the term breech trial, or TBT, was followed by a large reduction in the incidence of planned vaginal birth. Publication of the term breech trial, or TBT, was followed by a large reduction in the incidence of planned vaginal birth. Nevertheless, vaginal breech births will continue, not merely because of failure to detect breech presentation and the limitations of external cephalic version, but for reasons of maternal choice. Lack of experience has led to a loss of skills essential for these deliveries. Conversely, caesarean section can have serious long-term consequences. What information should be given to women with breech presentation at term? Women with a breech presentation at term should be offered external cephalic version, or ECV, unless there is an absolute contraindication. They should be advised on the risks and benefits of ECV and the implications for mode of delivery. Women who have a breech presentation at term following an unsuccessful or declined offer of ECV should be counselled on the risks and benefits of planned vaginal breech delivery versus planned caesarean section. What information about the baby should be given to women with breech presentation at term regarding mode of delivery? Women should be informed that planned caesarean section leads to a small reduction in perinatal mortality compared with planned vaginal breech delivery. Any decision to perform a caesarean section needs to be balanced against the potential adverse consequences that may result from this. Women should be informed that the reduced risk is due to 3 factors: the avoidance of stillbirth after 39 weeks of gestation, the avoidance of intrapartum risks, and the risk of vaginal breech birth, and that only the last is unique to a breech baby. Women should be informed that when planning delivery for a breech baby, the risk of perinatal mortality is approximately 0.5 per 1,000 with caesarean section after 39 plus 0 weeks of gestation, and approximately 2.0 per 1,000 with planned vaginal breech birth. This compares to approximately 1.0 per 1,000 with planned cephalic birth. Selection of appropriate pregnancies and skilled intrapartum care may allow planned vaginal breech birth to be nearly as safe as planned vaginal cephalic birth. Women should be informed that planned vaginal breech birth increases the risk of low APGAR scores and serious short-term complications, but has not been shown to increase the risk of long-term morbidity. Clinicians should counsel women in an unbiased way that ensures a proper understanding of the absolute as well as relative risks of their different options. The term breech trial, or TBT, randomized 2,088 women to either planned caesarean section or planned vaginal birth at 121 centers in 26 countries. This trial was by far the major contributor to the Cochrane Review, which demonstrated a reduction in perinatal mortality with planned caesarean section from 1.3 to 0.3%. This trial also reported a reduction in the composite outcome of serious neonatal morbidity. Elective caesarean section exerts a protective effect on perinatal mortality as well as short-term but probably not long-term morbidity, although the effect is smaller than suggested by the term breech trial or TBT. Some of the risk is due to the earlier gestation at which elective cesarean section is performed, while some is due to the elimination of labor, which even for a cephalic baby can lead to mortality. The excess risk of breech compared with cephalic labor is relatively small, 1 per 1,000, and implementation of strict selection and intrapartum management criteria, together with skilled support, may reduce it further. Perinatal mortality is also slightly increased by vaginal birth after cesarean section or VBAC, which nevertheless remains a common option. Any benefit from elective cesarean section must be viewed in the light of the small increase in complications associated with subsequent pregnancies. Furthermore, cesarean birth has been associated with long-term health issues in the offspring. What information should women having breech births be given about their own immediate and future health? Women should be informed that planned cesarean section for breech presentation at term carries a small increase in immediate complications for the mother compared with planned vaginal birth. Women should be informed that maternal complications are least with successful vaginal birth. Planned cesarean section carries a higher risk, but the risk is highest with emergency cesarean section, which is needed in approximately 40% of women planning a vaginal breech birth. Women should be informed that cesarean section increases the risk of complications in future pregnancy, including the risk of opting for vaginal birth after cesarean section or VBAC, the increased risk of complications at repeat cesarean section, and the risk of an abnormally invasive placenta. Women should be given an individualized assessment of the long-term risks of cesarean section based on their individual risk profile and reproductive intentions, and counselled accordingly. Maternal outcomes, particularly short-term, depend on the category of lower segment cesarean section, with emergency carrying a higher risk than elective. Emergency cesarean section rates with planned vaginal birth vary from 29% to 45%. For subsequent pregnancies, having had a planned cesarean compared with planned vaginal birth causes a threefold increase in uterine scarring. More than half of all women with at least one prior cesarean section have another. The risks of blood transfusion, endometritis, hysterectomy, and death are increased in women with a previous cesarean section, irrespective of whether they attempt a vaginal birth after cesarean section, when compared with those who have previously delivered vaginally. The risk of scar rupture during attempted vaginal birth after one cesarean section is approximately 0.5%. In developing countries, particularly where birth outside hospital is usual and access to healthcare is poor, the effect on maternal outcomes is likely to be considerably greater. A further maternal issue is that of placenta previa and placenta accreta, or abnormally invasive placentation, for which prior cesarean delivery is the principal risk factor. The risk of abnormally invasive placentation increases from 0.31% with one prior cesarean section to 2.33% with 4, and the incidence is rising. The risk is higher after elective compared with emergency cesarean section. This complication can lead to massive hemorrhage, hysterectomy, urinary tract injury, and maternal death. What information should women having breech births be given about the health of their future babies? Women should be informed that cesarean section has been associated with a small increase in the risk of stillbirth for subsequent babies, although this may not be causal. Future pregnancies are also at risk of uterine rupture, When vaginal birth after cesarean section is attempted, the risk of delivery-related perinatal mortality after one cesarean is up to 12.9 per 10,000, much of which is attributable to uterine rupture. What factors affect the safety of vaginal breech delivery? Antenatal assessment. Following the diagnosis of persistent breech presentation, women should be assessed for risk factors for a poorer outcome in planned vaginal breech birth. If any risk factor is identified, women should be counselled that planned vaginal birth is likely to be associated with increased perinatal risk and that delivery by cesarean section is recommended. Women should be informed that a higher risk planned vaginal breech birth is expected where there are independent indications for cesarean section and in the following circumstances: hyperextended neck on ultrasound, high estimated fetal weight more than 3.8 kilograms, low estimated weight less than 10th centile, footling presentation, and evidence of antenatal fetal compromise. The role of pelvimetry is unclear. The safety of planned vaginal breech birth is dependent on case selection, operator skill, and intrapartum management. There is, however, a paucity of good evidence regarding factors that increase the risk of vaginal breech birth: skill and experience of birth attendant. The presence of a skilled birth attendant is essential for safe vaginal breech birth. Units with limited access to experienced personnel should inform women that vaginal breech birth is likely to be associated with greater risk and offer antenatal referral to a unit where skill levels and experience are greater. Although largely unproven, the availability of skilled personnel is likely to strongly influence perinatal outcomes. An inability of a unit to reliably provide experienced personnel for the delivery is a contraindication to a recommendation of planned vaginal birth. Intrapartum assessment and management of women presenting unplanned with breech presentation in labor. Where a woman presents with an unplanned vaginal breech labor, management should depend on the stage of labor, whether factors associated with increased complications are found, availability of appropriate clinical expertise, and informed consent. Women near or in active stage of labor should not be routinely offered cesarean section. Where time and circumstances permit, the position of the fetal neck and legs and the fetal weight should be estimated using ultrasound, and the woman counselled as with planned vaginal breech birth. All maternity units must be able to provide skilled supervision for vaginal breech birth where a woman is admitted in advanced labor, and protocols for this eventuality should be developed. UK data reported that breech presentation at term is not diagnosed until labor in about 25% of women. In some women, labor will be so quick that vaginal breech birth is inevitable and assessment using ultrasound is impossible. Unplanned vaginal breech birth is associated with increased risk, but the data on planned vaginal birth cannot be simply extrapolated to support routine late labor cesarean section. Where labor is progressing rapidly, there is a balance of risk. Attempting cesarean section where the breech is very low is likely to be associated with increased perinatal and maternal risk. Assessment should include what is feasible. Attempts at vaginal delivery in theater with spinal anesthesia or cesarean section with a breech on the perineum are likely to be associated with both increased perinatal and maternal risk. What is appropriate intrapartum management of the term breech? There is a paucity of evidence regarding the best management of the breech fetus in labor. Recommendations are based on physiology, best practice experience, and the management protocols of series with low complication rates. The limited evidence and expert opinion broadly divides into two groups: a more interventionist approach supported by data from the large pre-MODA study, and a less medicalized approach which is more traditional in the UK. Both strategies advocate close supervision and the not infrequent need for cesarean section or intervention during breech birth. Are induction and augmentation appropriate? Women should be informed that induction of labor is not usually recommended. Augmentation of slow progress with oxytocin should only be considered if the contraction frequency is low in the presence of epidural analgesia. As a means to treat dystocia, augmentation should usually be avoided, as adequate progress may be the best evidence for adequate fetal-pelvic proportions. However, if epidural analgesia has been used and the contraction frequency is low, its use should not be excluded. Notably, labor augmentation is not supported by many experienced advocates of vaginal breech birth who favor a less interventionist approach. What is the role of epidural analgesia? Women should be informed that the effect of epidural analgesia on the success of vaginal breech birth is unclear, but that is likely to increase the risk of intervention. Vaginal breech birth is usually easier if a mother is able to bear down effectively, and an epidural may interfere with this. A less interventionist approach advocates a calm atmosphere with continuous support as a means to avoid epidural analgesia. With a more interventionist approach, seldom used in the UK, epidural analgesia is less likely to have a detrimental effect.